terrible. 2, 3, 4, 5. You can clearly see we're at the right disc. Pull harder. Push in with the shoulders. Shot. Are you giving me everything you got on the shot? Yes or no? Jordan, that's a question to you. All right. Shot. Pull on the arms. Can't you get me a better view down there? Oh, those are your rings. That's funny. I need a better view at 6, 7. We're definitely in, but I need to be able to see the needle. Nope. Go get Monica, please. All right. Good morning. It's Dr. Deuk Majan, and we're here at the Deuk Spine Institute performing a Deuk laser disc repair on the cervical spine at C6-7. And at this point, we're localizing. You pulling in line towards you? Good. Shot. All right, what is that wire? We got to get rid of that EKG lead. It's right in the way. Take your time. It's around the shoulder somewhere. Everyone relax. All right, so our patient has a herniated disc. Yeah, you cannot come into the sterile field. I hope you know that. Yeah, you should be further lateral to where your hand is. It's way too medial. No, it's way too medial. Stay away. It's literally coming over his chest. All right, well, definitely in the C6-7 disc, that's for sure. And it's hard to tell where the end of the needle is at this point, so we're going to just give this a minute. What we're doing is we're making an adjustment. We're using X-ray to guide the surgery using a lateral view, which is a side view, shot, and an AP view. No, it's still there. You don't see that wire? It may be the other side, guys. Come on. That's what it is. It's an EKG lead. That's what she's looking for. No, this is coming anterior. Our patient has injured his disc in his neck. He has a herniated disc at C6-7, and we're going to be attempting to perform a Deuk laser disc repair. His neck is a bit short, so it's very hard to see the bottom part of the spine, the cervical spine, which is where C6-7 is. Honest to God, this is honestly, I've never seen an EKG lead take so long to locate. Are you not able to find it? Shot? No, it's still there. That's great. It's some wire or lead going across his chest. You want me to scrub out and come help you? Why was that so hard, guys? Honestly, I don't get it. The surgery is hard. Finding a wire across the chest shouldn't be hard. All right. Anyway, let's get another shot. Go. That's fine where you are. Pull the shoulders. Pull the head, please. Pull the head, please. The head in line, please. Ay, ay, ay. 2, 3, 4, 5, 6, 7. So we are definitely at C6, 7. And it looks like the needle is, come on down south further. And is Monica here? Good. We need to see that C6, 7 better. It's going through a lot of shoulder material. So how's our blood pressure? Is perfect. Any way to see that a little better? To me, it looks like we're at the front of the disc, which is fine. We're right in the midline according to our AP view. I just want to make sure we're not back too far. All right, so the access of the disc is the first step. And that's what we're doing right now. We're accessing the C6, 7 disc. And it's pretty collapsed. He's got a good size herniation. I just can't make any progress advancing the needle. Can you take a shot? Hey, that's better. All right, it looks like we're in the middle of the disc, which is good. I'm probably hitting a bone spur. I'm going to go ahead and do our discogram. No, stay here. We need your help. Okay? It's not the... Send Jordan then. Give me a pull. I need to be able to see that disc. Shot. All right, there you go. There's some dye coming out. Shot. All right, that's probably the best we're going to get. So let's just stop and regroup. We need about just a few more minutes. He doesn't seem like he's relaxed enough to me. He's still pretty tense. Let's get a quick AP. Is there any way you can give me a little more relaxation? Everything okay over there? Your IV working? All right, good. All right. Yeah, we didn't get much dye out. But we're right in the middle. That's perfect. All right, let's go back to a lateral. Again, the procedure you're watching is a Deuk laser disc repair. If you're not sure what that is, go ahead and look it up. We've published the Deuk laser disc repair technique in the National Library of Medicine in PubMed. If you go to pubmed.com, you can find it. We have several papers published. They're peer-reviewed and published. This is a FDA-approved equipment, and everything we do here is FDA-approved. In case you're wondering, this is an endoscopic type surgery. Why are we flexing his head? Yeah, do you have twitch? You have the twitch monitor?
I have twitch monitor, no twitches, except that was a tetanus that I gave him just to see
Uh huh.
if I have some residual, but no.
All right. Let's go back to our lateral view. So at this point, we need to gain access to the disc, which we've done with the needle, and now we need to put a guide wire and get our dilator in. That's pretty good right there. That is pretty good. You can see we're just anterior in the disc space. Let me look at the MRI one more time. And it's a pretty collapsed disc space with a herniation. Do you have the MRI, John?
No, I do not.
Okay. All right, I'm going to make the incision, so relax. That was last shot you guys had was a really nice one. If you can give me that a couple more times, I'll be happy. I'm going to do a little local, just under the skin. We use a little lidocaine with epi. It's just to numb up the skin while we make the incision. Sometimes we get a little bleeding here, and that's just from some superficial veins. So you're totally relaxed, right? And I got my guide wire anchored, so we're going to bring this needle out of the disc. And again, we didn't get a very good discogram because the disc space is so collapsed from the injury to his disc. That looks good. And I did make the incision before I took the needle out this time because I wanted that extra stability of the access. It's hard to see with all the shadowing. All right, so we're going to bring our dilator down. Let's get a shot. That's beautiful. I'm stabilizing this guide wire and I'm passing the dilator through the soft tissues in the neck. Now generally we go around the shot. We go between the, yeah, we need to clean that up a little bit better. Some of it's the Raytech, but I feel the spine. I feel like I'm in the front of the disc right now at C6-7, which is the disc we're fixing. I will need some inline traction. Again, not yet, but in a minute. Let's get a shot lateral first and see where we are. That looks pretty good. And then now I need an AP. And I'm going to need to see that a little better, guys. Nobody, is somebody not pulling the arms? You are? Are you able to actually pull his wrists a little bit? Let's get a shot. That's in the midline. That's perfect. You can actually see the guide wire going into the disc. All right, it's perfect. It's actually better than I thought it would be. All right, take that. I will need a little inline traction as I advance the dilator. Get over there and get those shoulders. All right, you guys ready? Shot. Let's see what we got. All right, that's any way to get a little better than that? So the reason this patient's disc is not easier to work with, shot, is because they have a lot of inflammation inside the whole disc, it appears. And that has caused some scarring in the actual front of the disc and shot. In the front, you can see the guide wire is going about halfway back. That's really good, guys, on the x-ray. I just need to get this anchored and then we could use the mallet. Are you extending, shot? I need you to extend inline traction with slight extension. Kind of rock his head back. And he's relaxed still, right? Okay, good. Shot. All right, we got that started. That's good. I'm going to take the guide wire out. I need the mallet. Now this is where I need the best pictures. Shot. Give me inline. Shot. That's pretty good, but yeah, this is so collapsed. This is just so collapsed. I can feel it. It's really tight. Shot. That's perfect, guys. You've done a really good job on the x-ray. Man, that is ugliness. That's about as good as we're going to get it. Let's see what we got in there. Huh? And this has really pushed us down against the collarbone. The idea here with the surgery is to repair the herniation and the annular tear without actually taking the entire disc out and fusing him. So patients who have this procedure can avoid having a fusion or any metal or anything artificial put in their body long term. Shot? All right, so that's a perfect x-ray picture, guys. You're doing a great job. I got to advance this without moving the dilator forward. We're almost done. So tight. You're really pulling on that neck? Yeah. Inline traction. Jeez. Yeah, that's unbelievable. So you got to make sure that comes out, right? it's just so tight. Incredible. I better go on there. Shot. Shot. I felt that move. Shot. And it moved again. Shot. Shot. That's good. We're just about there. And he's totally relaxed, right? All right, well, let me see. Hold on. I may just do one more. It's pretty close to being as good as it's going to get. Shot. And this one more time. Basically, we're driving the tube that we're doing the surgery through a little bit further. Shot. All right, that's about as good as we're going to get it. Okay. You have material there that needs to come out. All right, you can go. Thank you. Tough one, for sure. What's made it so difficult is how collapsed this disc space is. So his MRI, what's the date on the MRI? I don't think that's going to work. I don't know. Huh? What is it? All right. So we need to get this dilator out without crushing the end. Otherwise, that'll close the hole off. Let me see. It's somewhat cold welded at this point to the tube that we're doing the surgery through. Oh, nice. You did it? Yeah. Sterile high five? Awesome. All right. You got this, John? Can you see this?
Yes, we can see it.
And, you know, what's interesting, and actually, all right, you want to take a shot? Let's get a shot. Yeah, it looks good. That's as good as we're going to get it. I could not get any further in, so we're going to have to take a look and see what we got. And the goal here is to basically treat the patient's herniation, which is two things, an annular tear and then the herniation itself that's sticking out. We want to get rid of those, repair the annular tear, get rid of the herniation of the nucleus pulposus without actually fusing this patient's neck, which requires metal and bone graft biologics. There was a story in the news last week, and it's still ongoing as a matter of fact, about with fusion surgery you have to use something called bone graft, and there's a story right now going on in the news about how one of the company's bone graft was infected with tuberculosis, and now there are 100 plus patients who had that bone graft put in and have tuberculosis, and they're suing now, of course, the company that had the tuberculosis in their bone graft. So the point is that, you know, if you can repair a herniated disc without putting bone graft, without putting metal, without putting PEEK or anything unnatural in the spine, it's better. And this procedure, this Deuk laser disc repair, is the only procedure in the world that allows that to happen. And it's a type of endoscopic surgery. So it's very state-of-the-art, advanced. Again, everything is FDA approved. The only problem is with this particular case, this particular patient, you know, he's got a pretty good sized herniation, but his disc space is totally collapsed. And that's really limiting my ability to get to the actual herniation itself. Keep him very relaxed, okay? My anesthesiologist is going to keep the patient as relaxed as possible, but I have some concerns because of the fact that I can't get really that deep. And I told the patient before surgery there's a chance we won't be able to to do the surgery for one reason or another. But I still think it's worth trying. And in this case, the things that would limit my ability to do the surgery would be the patient's neck anatomy, which honestly it was a close call. We got it done, but it's a close call. And then of course the actual disc anatomy, the anatomy of the herniation itself, whether I can get deep enough into the disc to get to it. And that's what we're going to try to see what happens here. So a lot of times I can get in with the laser and start removing the herniation and the scar tissue, and these are all little fragments of herniation right there, like that piece right there. And so when I start removing these fragments, a lot of times what happens is the bones start to move more naturally, like a normal bone would move. This is not normal right now. Like these two vertebrae on both sides of this disc are just not moving at all. They're stuck together, basically glued together like with super glue, okay? But there is no super glue, obviously. It's just scar tissue from the herniation itself. So that's another factor you have to take into consideration when you're doing this type of surgery is, you know, are you able to get into the disc and remove the herniation? That's part of the herniation right there that we're zapping away, okay? But you can see it's deeper than I'm able to get easily. I have to really work to get to it. And, huh?
The brightness, you want it down a little bit? Lower a little bit?
The brightness is okay for now. I could probably improve the what do you call it? Clarity, the sharpness. There we go. It's really a nice picture, actually. When you think about it, this is a fiber optic scope. So you're actually got all these little fibers. And if you look really carefully, you can actually see them. So right now, another thing limiting me is the patient's chest. His chest is big. He's a big guy. He's got a burly chest. And that's keeping me from getting deeper because it's blocking my scope. So these are all things there's no way to know ahead of time until you actually get in there and start doing the surgery. But this is part of this is the back of the herniation. There is a deeper part to it. And you can see the herniation is really scarred in there. Clearly. So the alternative to this would be an anterior cervical discectomy and fusion. And patients don't want fusions. They just don't want to be fused. I don't blame them. It's so unnatural. We used to fuse people's like joints, like their hips and knees. And then we developed this artificial disc technology. And that's not an option in this case. Artificial disc would not work for this patient. The reason is simple. There's too much scarring of this disc. There's not normal movement. There's too much scarring. There's a piece of herniation right there coming out of the foramen. Okay? I'm going to try to float it out. Sometimes I can't. They're too heavy, too dense. Sometimes I can break them up with a laser and then they float out. Okay? Any questions from our audience so far? You're watching an endoscopic spine surgery. This is an alternative surgery to the fusions. Better option. And this patient has a herniated disc at C6-7 on the right side, and we're in the right foramen right now. Actually, we're close to the right foramen. I'm just floating out fragments of herniation that we're releasing by releasing the scar tissue around the fragment. And that scar tissue forms in what's called the annular tear. And the annular tear is the area where the herniations pass through to get, and by the way, I'm also removing some bone spur here. You see that? So by removing some of the bone spur, I may be able to get this tube to go deeper. But right now, I can't get my working cannula to go deeper because it's so scarred inside this disc from the herniation, causing so much scarring. So I'm trying to free things up. Any questions?
No, not at this moment.
Nah. All right. Everybody knows everything. So we broadcast our surgeries live. Almost every single surgery we've done has been broadcasted live. There's been a couple of patients who didn't want it broadcasted live, but most of them do, and they're happy to have other people watch and learn. I would say 98% of our patients are fine with broadcasting. Of course, we get their permission ahead of time, and they sign a permission, a release. And it's nice because they can then go back and watch it with their families online if they want to. You know, it's something nice for them to do. Also, other people get to learn. So this is like being in a classroom, except rather than showing you pictures or pre-recorded videos, you get to watch the real deal, the real thing. And you get to see the challenges that the surgeon faces. You know, it's not easy. Every case is not easy. We have different challenges with different patients. So you get to see how the surgeon overcomes those challenges during the course of the surgery. Really want to shave down that wall a little bit. Take that. Move it over here. So you got to figure out how this is going to go, Luis, so you don't get all these cables and everything mucked up like this. Okay, you got to test it first. So this wall right here is full of scar tissue, and there's some spur, and I want to be able to go a little further in with my tube, but to do that I have to first clean this up. So every case is different. In principle, they're all about the same. And you know, what's unique about the Deuk laser disc repair procedure is the fact that we repair the annular tear by debriding it. We don't actually close it up. Some people mistake a debridement for closing it up. We clean it up so that it'll heal. The problem is the annular tear is unable to heal currently. And it's unable to heal because there's nuclear material, disc material stuck in it. It's like right now I'm trying to get lateral here, or more closer to the midline, I'm sorry, and I'm having a hard time because of the patient's anatomy. His chest again is very high, and it's actually bumping up against my equipment, limiting my ability to go down. There's nothing I can do about that, except maybe someday develop a scope that's longer. Right, Luis?
Yes, sir.
May not be a bad idea. A longer scope. All right. So we're inside the herniation here at C6-7. I'm just peeling it away half a millimeter at a time, basically. So people wonder about the laser. Is the laser precise? Absolutely. The actual energy released from the end of the laser fiber goes out about half a millimeter, and then it stops. So you don't have this very dangerous tool that can cause damage. You know, something like a metal grabber or something like that can actually cause more harm than good. So now we're starting to get a little bit of movement, a little play, and that's good for me because it allows me to get into places that I haven't been able to get into previously. Okay? And you can see removing a herniation is not a quick and easy thing. It actually takes patience and time, and you gotta literally blast away little bits at a time. Okay? So I'm gonna try to manipulate my tube and get a little more lateral towards the foramen. I've encountered another little fragment of herniation here. And it's extremely scarred up. We call it collagenized. So if a fragment of disc herniation undergoes a remodeling process in the body, and that's all due to inflammation from the annular tear. And that remodeling starts out with what's called collagenization. And collagenization is basically scarring. And the reason it gets scarred is inflammation. Inflammation is a process where your body attacks things that it perceives as foreign, shouldn't be there. So it sends these cells to come and get it, like little soldiers. And each soldier has its duty, its job. Macrophages, for example, eat up debris, and polymorphonucleosides, or PMNs, they're part of your inflammatory system. They release what are called digestive enzymes, which, are proteases and lipases, and they basically attack the foreign body chemically, and macrophages attack the foreign body physically. So one soldier produces chemical warfare against this herniation. The other one does, trauma, so to speak, and cleanup. And then you've got the fibroblasts, which come in and basically form scar tissue as part of that inflammatory process and healing. Okay? So you got different cells doing different things, and ultimately they all result in a lot of scarring, because of the fibroblasts that get called in. And then of course you have the ingrowth of new blood vessels and things like that, nerves, and that's where the pain comes from. There's all the little nerve fibers that grow in there. And those nerve fibers actually they cause the feeling of pain in that inflamed area. So it's a whole process that ultimately results in heavy scarring and pain and destruction of this whole area over here. So we're in here to repair that. And the way you repair it is by removing the foreign body, first and foremost. Let's just have a grabber, standby scope and laser. See if I can get out in the foramen and grab a piece of that herniation out. I'm using a pituitary, which is long, and it has a little grabbing end. Typically what I'll do is I use a laser to debride the annular tear, and then I use the pituitary to take out pieces of herniation that don't just float out on their own. So herniation fragments are removed by hydrostatic pressure, which is the fluid going through, circulating, and they're removed by mechanical, which is the pituitary. Yeah, I'm having a lot of resistance to, look at that scar tissue there. That's what's blocking me from going deeper, right there. All this scar tissue. Oh, laser is on? Thank you. So I'm kind of working around the tube. That's all just dense scar tissue. So I was telling you the process of inflammation involves, scar tissue, but it also involves calcification. So if inflammation goes long enough, the tissues that are scarred and damaged become calcified, and there's a name for it. It's called dystrophic calcification. We've talked about it before here. And basically dystrophic calcification is the calcification of damaged tissues. It doesn't happen without inflammation. Wow. It requires, inflammation, chronic inflammation, and then you can get calcification of those tissues. So Any questions from our audience?
Yes, a viewer is wondering if the laser beam specifications are the same in both cervical and lumbar DLDRs, or whether they differ.
Yeah, the laser specification's the same for both cervical, which is the neck, and lumbar, which is the lower back. The answer is yes and no, as most of my answers are. Yes, the laser fiber is the same, and yes, the laser machine is the same. Why are we getting so much rundown? This floor is all wet. You know, you gotta... I got other things to worry about, guys. Standing in a pool of water. So if the bag is not set up well, then you get, there's a piece of herniation, by the way. Then you get a liquid, this fluid that we're using to irrigate and cool ends up going onto my feet, which is not ideal. All right, so the fiber is the same, cervical and lumbar, and the laser machine is the same for cervical and lumbar. What is different is the amount of power we use. I'm sorry? That's fine. All right, I'm trying to go a little bit deeper now because I've freed the bones up a little bit so you can see them moving when I twist. Those are the vertebrae. Let's take the scope out, laser off. And I need to advance the cannula a little bit more. So I want the dilator.
Lights on, please.
Mallet.
I mean, the other one does.
Huh? What?
No, I mean the other lights.
And then...
Thank you.
Let's see what we've accomplished. Take this. This thing is stuck as usual. There we go.
Okay, thank you.
Let's see if we've made any progress here with advancing this. That's good. Scope on.
Lights off, please.
So I don't know if I answered the question well, but it's a little bit of improvement, but all right. This damn thing, gotta keep it over there. You got too many squiggles in it. It should be straighter. And the scope not lined up. All right, did we answer their question?
I believe so for the most part.
Huh?
Yes, I believe so. They were just wondering as well as, like, does the beam size and divergence of it differ as well, such as the wavelength and pulse rate?
Oh yeah, the beam size, the pulse rate, pretty much the same. Now that is looking out the foramen. And again, I'm limited by his chest, but we're definitely getting some better movement of this tube, so I can see further to the side, to the right side, which is where his herniation is the worst. You see that? But we're still pretty limited by his anatomy. There. Now that to me looks like a pretty good sized herniation down there. See it? That is. pretty good size herniation right in the foramen. Yeah. All right. That is a good size herniation right in the foramen. So I'm going to try to get in there as much as I can by removing the blockage of the tube, which is a lot of this scar tissue and calcified scar tissue right here off the end plate. That's going to be the end plate of C7. You can see C6 is here. And I really want to get down into that foramen there. So I'm going to keep working this thing. Almost like, I hate to say it, but drilling, right? Let's see if I can grab it out. It looks pretty scarred down to me. I don't think we got it. Nope. So great question so far today. Thank you for asking. Who is our viewer that asked? It's always nice to know where they're from.
It is a Facebook viewer.
I'm sorry?
It is a Facebook viewer.
Facebook. All right. So once again, this is just you can see the goal. It's unfortunately, it just takes time to try to work it carefully and get the work done. But in this case, like I said, normally it's a lot easier to get out in the foramen. But because of this patient's anatomy, his big chest, his clavicle, you know, all of those anatomical reasons, it's harder. So we're not going to give up. We're going to keep going. I just have to redirect and try to extend the laser fiber a little further. Let's see if I can get a little bit more lateral. I'm definitely making progress. Let's clean that wall a little bit and then see if I can advance it like we did earlier. You know, a little bit more. This is definitely a harder case to do. Even though it's a one-level case, a one disc, it's still presenting some really unique challenges in that the herniation is so far out in the foramen, so lateral, and the disc is so collapsed that it's really forcing me to work hard to get lateral enough, just because of his anatomical constraints. All right, yeah, I'm going to try to advance it again, scope off. I'm just going to use the mallet. I think there's really nothing to biopsy at this point, so it's just about getting it, there we go, getting it a little bit further. And again, we broadcast because we want that, you know, in the future, we want people to see how we problem solve and how we troubleshoot. So it's about sharing information. Okay. That gave us a little more better perspective and access. Let's see what we can do with it. Some of what we're dealing with in the foramen is foraminal ligament. So it's a ligament in the foramen. And the way the surgery works is you're just going to peel away layers of tissue a little bit at a time. Let's try a little more.
I'm sorry, what? Let me know, but it's not that.
Scope on. You think the ray tech around the wrist would help more?
No.
All right. So much scar tissue here. This is really just scar tissue. This is just ridge of an osteophyte. I mean, the blush you're seeing there is the just above the dura. We don't want to mess with that. So, all right, let's go back to the midline, more central, and let's see what we can find here. There's still some herniation there. Let's swing this around. And all right, so we're going to work the opposite direction and try to come towards the midline. One of the things that I've noticed over the years of doing this surgery is that we're really able to improve the mobility of the segment quite a bit just by removing the scar tissue, what's called the annular debridement. And by debriding the annulus, I'm able to really free up the movement of the disc, whereas prior to the surgery, a lot of these discs don't have any movement because they're so scarred up. This is all scar tissue, by the way. This whole white thing that looks like a glacier is just massive amounts of scar tissue and fragments of disc herniation, all embedded within the annulus. And yeah, we're getting a lot better movement of this gizmo, the laser rig now, because we've removed some of the scar tissue that's really locked these bones together. So we're heading towards the middle of the disc. And his herniation really is kind of a broad-based paracentral with a foraminal component. I'm going to go back and look at his MRI again in just a minute, but I want to make sure we get as much out as we can. Safely. The key word is safely. Let's go ahead and put the scope on hold. Laser on hold. Let me look at that MRI one more time. Sometimes I like to go back and look at the MRI, the preoperative MRI, and just see how are we doing. Actually, it looks like we're doing pretty good. The other way. Yeah, all right, I think we pretty much got it. I'm going to clean up the middle a little bit, and I think we've got it. I mean, we got some pretty good chunks that came out early in the surgery from the foraminal area, and yeah, I'm pretty happy. I don't want to cause any damage, so we don't want to, just stay here doing nothing. We want to make sure that we're being productive with our time. One of the worst things I fear in surgery is you don't want to just operate to operate. You want to have a goal, a very specific goal the entire time, and make sure that you're reaching that goal, achieving that goal. Because the longer you keep a patient under anesthesia just goofing off, trying to figure out what you're doing, the more anesthesia risk and bleeding risk and operative risk you create for that patient. So it's important to to always keep in mind why you're there. You're there to fix a problem, and as long as you're working towards that goal productively, then you're going to have good results. But if you start dilly-dallying and not really doing much, then you gotta at some point say, all right, I've done everything I can do for this problem, and let's hope it's going to work. I'm kind of moving the tube around a little. I want to get a little more of this scar tissue. I'd say 5 minutes max. 5 minutes. There's so much scar tissue from inflammation. And it's just built up across the whole back of the disc. Right where the spinal cord and nerves are. So a lot of people come to us with herniated discs in their neck, and they've got headaches that shoot from their neck up. And this is why, folks, it's all this inflammation. The inflammation gets onto the covering around the brain called the dura. It's right there. You can actually see the dura. That's the dura right there, okay? And that inflammation is socked onto the dura, from the herniated disc. So basically, it spreads around the brain and it causes a headache. And a lot of doctors don't even know about those headaches. They don't realize that the herniations in the neck can cause headaches. They don't cause migraine headaches. They cause what's called a cervicogenic headache. Cervicogenic means it comes from the cervical spine. Genesis means to originate from. So these are headaches that come from the neck. And these people always have neck pain. And the neck pain rises up into the back of their neck in the occipital region. And they get these horrible occipital headaches. There's a piece of herniation. It's a little bit of the end plate of the cartilage stuck to a herniation. Again, as a result of inflammation. Inflammation is a very destructive process. And we know in medicine there's lots of inflammatory conditions. As a matter of fact, pretty much everything that harms the human body does so as a result of inflammation. Not 100%, but pretty darn close. Whether it's an infection, like by bacteria, creates inflammation. Whether it's a foreign body, like something stuck in your body that shouldn't be there, like a stick or anything, a piece of metal that is not clean, that's not biologically compatible. It creates inflammation. Even spinal implants, the implants we put into people's spines create inflammation. That's why they get scar tissue around them. Scar tissue is a result of inflammation. And there's a tremendous amount of scar tissue right here in the back of this disc. And we're not here to remove all the scar tissue. We're here really to get rid of his pain and remove the herniation that's causing the scar tissue. If we do that, then we've been successful at treating him. And that's our goal here. Come on. Get out of there. That's a little piece of herniation I'm trying to break up and get out. Let's float that thing out. Now that pink area you're seeing on both sides are the end plates. And end plates, let me have the grabber.
Yes, sir.
Try the grabber. The end plates are the bone surfaces of the vertebral bodies on both sides of the disc. I don't know if I got it there. No? Huh? And the end plates we're not messing with. But obviously, please don't pull. Obviously they're exposed in the surgery because we're working on the disc. And a lot of these discs, herniations, they involve degenerative disc disease as well. So that's kind of what we're seeing here. Just about done. Don't want to gild the lily. More scar tissue and herniation. You can see how effective the laser is at getting rid of it. And then I'm going to take one more peek over there in the foramen. Get that guy out. We call that floating. We're floating out a piece of herniation. See the grabber? Actually, almost bent the grabber. Felt like I got a pretty good grab on there. Let's see. The nice thing about this system is that you can actually aim it back and forth, you know, inside the disc, across the patient's disc. Yeah, I've done everything I can there. All right, we're done. Sorry about the wet floor. All right, if you have any questions about the surgery, we're pretty much done. We will show you the actual incision in a second. Luis, I mean, if you study what's happening here, part of the reason the bag is filling up is because that thing is getting pulled that way, so it's lifting up. It's lifting like this because the tube is getting pulled. You need to have the tube going straight down. So if you have the tube going underneath this pole, underneath the leg of the pole, and then to the suction, then that will be straight down and the water will go in. You gotta develop a system that works for you. You really shouldn't be having these issues. All right, can you guys see over here? Everybody see?
Yes,
John,
we can.
you can see the incision?
Yes, we can see
So
it.
the whole surgery is done through this tube. It's about 4 millimeters outside diameter tube. And we're going to be taking it out right now. Our patient is asleep completely for this type of surgery. We don't keep patients awake. They don't need to be awake. Whereas with the lower back surgery, we keep the patient awake for the first few minutes while we get access to the disc. Because it's different type of procedure, we go through a different territory. We need the patients awake to help us. But for the cervical, it's important they're completely asleep and completely relaxed. So we use neuromuscular blockade, muscle relaxers, and the one we use typically is rocuronium. Is that what we're using? There's a bunch of different ones, but we use rock. So our patient is intubated, asleep, under general endotracheal anesthesia with rocuronium, completely relaxed. Otherwise, you're going to be fighting the muscles of the neck, and it's really hard already to do the surgery, and then to have to fight the muscles. All right, so we apply pressure for about 4 minutes, and the reason is we don't get arterial bleeding, but sometimes we get a vein that's nicked and it's going to bleed a little bit. So you want to apply pressure, because for veins, they run at about 10 to 12 millimeters of mercury pressure. And we want to apply 10 to 12 plus 1 millimeters of mercury pressure to keep the blood from coming out of that tear, if there is one. I have no idea if there is. I just do this every case anyway. Sometimes we do get a little bit of bleeding. It's minor. I think we lost maybe a few drops of blood here. This is pretty much bloodless. All right, take a look at the incision. You guys see that? And there's a little vein at the surface there, no big deal. And that's how the surgery is done. Go ahead and type up your questions if you have any. I'll be happy to answer them. But we were successful at getting into the C6-7 disc, and I feel we did probably about 90%. And again, we were really severely limited by the patient's own anatomy. His barrel chest, he's got a big chest, and his collarbone and his short neck. And then, of course, the seriously collapsed disc made it really hard to get all the way to the back. But we did a good job, and I think he'll do well. Any questions? If so, type them up, and I'll answer them in a couple of minutes. Great job, everybody. Hey, I love these gloves, Luis.
You like it?
Yeah. Countdown 3, 2, 1. 3, 2, 1. Good. Okay, good morning. I'm Dr. Deuk. We just finished a cervical Deuk laser disc repair for a herniated disc and degenerated disc at C6-7. This patient has had neck pain going into the right arm. And so when I do a cervical disc herniation, just to give you an idea, if the disc herniation is kind of off to the right side or left side, I go to the opposite side of the neck to make my incision, because it's easier to go across the neck through the disc rather than trying to get to the same side as the incision. So what we're dealing with is a situation where you can see the disc here has a herniation. It's rubbing and irritating the nerve root. And so to get to that herniation on this side, I start in the skin incision on the right side or opposite side, and I hit the disc in the middle and I kind of cut across just like that. So my tube is at the base of that herniation with the laser, and I use the laser to zap away all the scar tissue in the back of the disc and the herniation. You could see through the endoscope what a great view we had. Everything was clear. I could see all the anatomy. Seeing things isn't the problem. It's getting access to the pathology to fix it. That's difficult. What every other surgeon in the world does that doesn't do the Deuk laser disc repair is they're going to come in and make a big incision on the front. They're going to come down and move everything over, move your voice box over and push on it so it changes your voice. They're going to, move the carotid artery, jugular vein over with the vagus nerve. They're going to get to the front of the spine, and we have to peel the muscles off the front of the spine. They're called longus colli muscles, and they literally run, in the front of the spine like this, up and down. And inside the longus colli muscles is something called the sympathetic trunk, which controls the sympathetic nerves to your face. So any kind of damage to that trunk inside the longus colli muscles during the open surgeries can actually cause trouble with your pupil and flushing and sweating. So you don't want that. We call that a Horner syndrome. Anyway, to do the traditional surgery, the surgeons have to make a big incision, move everything over, lots of scar tissue, lots of bleeding, lots of trauma to your neck. And then when they get to the spine, they peel the muscles off to expose the disc, and then they put in, metal and everything. They open this disc up, and then we clean out the disc with a shaver, get rid of the whole disc, just to get to that piece in the back, all right? So what does the Deuk laser disc repair do different? We don't make a big incision. We don't have to move everything over. We go between things with the tiny little tube. We get to the front of the disc, and I go past the disc into the back where the herniation is, and that's when we start our work. And I remove the herniation and the base of the herniation. I remove it. Say this is our tube. We come into the disc, pass through and get to the back, and then I can kind of wag my tube along the back of the disc where all the scar tissue and herniation is, cleaning up the annular tear. We call that a debridement. We're the first people in the world to do it. It's been published already in 2012. If you look up Deuk laser disc repair in PubMed, you'll see that I'm the first person in the world to discover and to treat the annular tear with an annular debridement. We then clean up the tear so that it can heal properly and get rid of the interposed herniation of the nucleus pulposus, the jelly from the center, which is wedged in there. We got a great animation. We're almost done. We're releasing it this week. You can find it on the Deuk Spine Institute website and our app. It explains the annular tear. It explains the herniation and why they cause so much pain. Most spine surgeons don't believe disc herniations can cause pain. They're literally in the dark stone ages of understanding neck and back pain and radicular symptoms, unfortunately. And so I've given up on trying to teach the surgeons. They're just so pig-headed and stubborn. I focus now on teaching the public. So if they're out there watching, they can learn. But generally, these educational surgeries are for teaching anyone that wants to learn. And hopefully, we're going to memorialize these principles and concepts so that in the future, spine surgeons do what's best for the patient, not what's necessarily best for the implant companies. So once we clean up that herniation, we take the tube out like you saw. We put a little anti-inflammatory medicine in there, and then we're done. There's no fusion. There's no metal. There's no plastic. There's no bone graft or cadaver bone. None of that stuff's necessary since we're not fusing the spine. Our patient is waking up right now, and we're going to have hopefully an interview in about an hour or less for you so you guys could see the patient and see how he's doing. All right, what's the first question?
With structural changes such as retrolisthesis or kyphosis, is this surgery still possible?
Great question. Somebody is asking me, with structural changes such as retrolisthesis or kyphosis, Is the surgery still possible? Hi, Julie. Come on in. Join us. So, what is retrolisthesis? What is kyphosis? Well, that's a great question. This person who's asking is asking about what are called deformities of the spine. And deformities have a lot to do with the overall alignment of the bones. It's called alignment, you know, are the bones aligned properly? So let's just take this lumbar spine. This is not a neck, but this is a lumbar spine. I'm looking for a cervical. I have one. I'll show you in a minute. But the lumbar is easy to show you. So this is a side view. You can see the vertebral bodies, and there's a disc between them. The normal spine has curves, okay? But not curves in every plane, specifically curves in specific planes. If you think about it, you could have, if this is the normal spinal alignment, you could have an abnormality of this plane, that way or that way. You can have, if you're looking front to back, you can have an abnormality of this plane, all right? Or you can have an abnormality where the bones actually slide on each other. So this bone could slide forward on that bone, or this bone could slide backward on that bone. And if the bone slides backwards, it's called retrolisthesis. If it slides forward, it's called anterolisthesis. And if the bone slides to the side, which happens in scoliosis, it's called lateralisthesis. So there's anterolisthesis, retrolisthesis, lateralisthesis, okay? So those are the three types of listheses that happen in the spine. And then you've got angulation changes. So the normal curvature of the cervical and lumbar spine, which are the parts we operate on 95% of the time, they are lordosis, which is a curve backwards like that, beautiful curve backwards. So kyphosis is a reversal of that curve, where it's curved forward. And there are diseases that cause kyphosis. And one of them is the collapsing of the disc can cause a straightening or kyphotic spine. All right? Another one is scoliosis, when you bend to the side and twist. So does this surgery, the question is, does the Deuk laser disc repair work in patients with listhesis, kyphosis, scoliosis? The answer is 100% yes. And the reason is simple. When you're dealing with kyphosis, scoliosis, listhesis, the patient's pain and symptoms are not coming from the curvature 98% of the time. It's coming from the disc. Again, disc has nothing to do with the shape of the spine. The disc, and specifically, it's a tear in the very back of the disc, just this little area where the tear is, called the annular tear. That is the only source of pain. That tear causes the back and neck pain. And so that's what my surgery fixes, the Deuk laser disc repair, and that's why we have so much success curing pain even in patients with deformities. Now, if somebody has a deformity and they have annular tears and their pain is coming from the annular tears, but they also have pain from, say, the facet joints, which are joints in the back of the spine over here, okay, unrelated to the disc, but part of the motion unit. If you're having pain in the facet joint and the disc, if we just fix the disc tear, you're still going to have pain in the facet joints. And that's why having the right diagnosis before you have your surgery is so important. That's why Deuk Spine Institute offers a free MRI review, free video conference, so we can make sure we're understanding the source of the pain properly. The Deuk laser disc repair fixes pain from a painful disc. And that pain always comes from a tear in the back of the disc, not the sides, not the front, but specifically the back of the disc, with herniated disc material stuck in it causing inflammation and pain. Again, animation is coming this week. You'll be able to see it. Great question.
Are there any other methods of debridement besides just the laser, or can you do a mechanical debridement, like trimming down the herniation?
So the question is, it's a very good question. I've never been asked it, but it's a great question. Are there any other methods of debriding the annular tear that you can use? So the answer is no. I don't believe that you can. That said, I haven't tried other methods because the laser debridement works so perfectly. There are surgeons who use a bipolar to do surgery on the disc. I don't feel the bipolar works as well, and I don't use the bipolar. We've talked about it before. It's not as effective, in my opinion, in my experience, and it's also more costly. So even if the bipolar was more costly and it was better than the laser, I would use it. But I don't feel the bipolar works as well as the laser. And as far as mechanical debridement goes, like using a pituitary rongeur or some type of metal instrument like a kerosene rongeur, pituitary, or even a drill to get in there and debride, they don't work very well at all. So that's why most surgeons can't fix the problem, is because they don't use a laser. So you really do need the laser. If you watch my surgeries, my laser surgeries, 98% of the time I'm using the laser. I literally just take the grabber and put it in and to grab out pieces of disc that are loose. Once I've loosened them up with the laser, freed them up off the annular tear. Great questions, by the way.
Are there differences in recovery time for the DLDR with cervical, thoracic, or lumbar spine surgeries?
Are there differences in the recovery time with the Deuk laser disc repair endoscopic surgery, whether you're doing cervical, thoracic, or lower back lumbar? The answer is no. All those discs take, so the recovery time is 1 hour for the patient. You literally, in an hour, you're up, you're ready to go. You could actually, I shouldn't say this legally, so don't take this the wrong way, but you could probably go back to work the same day. All right. Now, I'm not encouraging people to do that, but that's how quickly the recovery is. Now, with the cervical, we do general anesthesia with muscle relaxers. With the lumbar and thoracic, we usually do propofol sedation. So with the propofol sedation for the lower back and the thoracic, a lot of times you can go right back to work. I'm not saying you should, but certainly by the next day. And you can drive the next day. The recovery is immediate. There's no need for narcotic painkillers. We just use a gentle anti-inflammatory and a muscle relaxer if you need it. Most patients don't even take the muscle relaxer. So the recovery is extremely quick. With cervical, you've had general anesthesia. It's going to be a little bit longer. You may not, unless we do total IV anesthesia with propofol, which you can do, but I need the muscle relaxation to relax the muscles of the neck so I can get in there and do the surgery safely. So with cervical, it's probably a little bit longer recovery. People may feel a little sleepy and tired the first day. By the next day, though, you're ready to go back to work and do everything normal. So the recovery is generally an hour. At worst, it's that day, ready to go back to normal life the next day. However, the disc is now debrided and it is starting to heal, okay? So imagine if you have a pimple on your face and it's hurting and you're touching it and it's, oh my gosh, that hurts so bad. It's inflamed and swollen, you got pus in there. So you get in there and you pop it, right? You get rid of the bacteria and the pus. Now it's going to heal, but it doesn't heal immediately. It takes maybe a day or two to heal completely, right? Well, with the disc, it takes longer. It takes literally a year, 9 months to a year to completely solidly heal. So you can injure your disc after the surgery if you're not careful. And the greatest risk of injury happens with lifting heavy things or bending over and picking things up from the ground. So we tell everybody, don't lift anything over 25 pounds for the first 6 weeks after surgery. If you are having surgery with your neck, we put you in a neck brace for 6 weeks. If you're having surgery on your lower back, we put you in a back brace. So the braces can be taken off. They have a Velcro strap, and they're, for the most part, pretty comfortable, but nobody wants to be in a brace, let's face it. But they do help prevent re-injury to the disc. That said, our re-herniation or re-injury rate in our patients is 1%. About 1 in 100 will re-herniate. Most of the time, there's something they did that they shouldn't have done, but sometimes they don't report anything. They just say it just happened. So could it have happened in sleep while they're twisting and turning in bed? I don't know. I don't have all the answers, but the re-herniation rate's 1%. So about 1% of our patients will re-injure themselves.
What are the different ways that a patient's natural anatomy can hinder or be an obstacle during a surgery?
Wow, so that's a great question. What are the different ways a patient's natural anatomy can hinder the surgery? Well, so let's go through that. In the cervical spine, which is what we just did, somebody with a big chest or a high collarbone, if it's high up, or a short neck, like their head is just kind of down onto their neck, it's really hard to get in and see where you are with the x-ray machine. Broad shoulders are also another thing. So big shoulders, big husky shoulders, the x-rays from the machine can't penetrate through all that shoulder material. And so the visibility is poor. We use the very best x-ray machine in the world. It's made by Siemens. And Siemens is a German x-ray company. They're the safest, most effective, best x-ray machines with the best visibility in the world. Even using those machines, some patients we struggle. And this patient, for example, this patient had a high collarbone. He also had a really barrel chest. Chest was out here. And so when I'm working, with the scope, trying to get down and do the surgery, my hands in the scope are actually hitting his collarbone and his chest. Not hitting it hard, but rubbing up against it. And I can't get down in there like deeper to get what I need done. So those are some of the anatomical features that sort of make the surgery more difficult to do. Certainly if you're starting out doing these surgeries, you don't want to start on somebody with a thick neck. The positioning of the spine. So in this patient today, even though his neck is thick and short, actually the spine in there was actually forward. Okay, what do I mean by forward? Well, it's actually something most surgeons don't think about. But if you look at my side profile, right, my spine could be here, like it could be close to the surface of the skin. So it's like right there when I get in, or it could be way back here, right? And so there's a big difference operating on someone with a spine that's close to the front, coming through the front, versus operating on someone with a spine that's way back here. Because you gotta like go through more soft tissues to get to the spine. So somebody with a really far back spine is going to be really hard for me to push down to get the needle in safely. And I had to abort somebody, I think one patient in my career that had a really deep spine and a lot of soft tissues up front. So that's a consideration. Yeah, there's a lot. There's also bone spurs in the front of the spine, in front of the disc that could impede the needle from going in, collapsed discs, even deformity like listhesis, scoliosis make it harder. I mean, I've done now over 1,300 Deuk laser disc repair procedures, and everyone represents a different challenge. The easiest are going to be people with long necks that are skinny long necks. But unfortunately, I don't get to choose, who comes and who has a problem. We try to help everybody, so good question.
That's all.
That's our last question. I hope you enjoyed the surgery. Unfortunately, we had to cancel our first case, which was a multi-level fusion. The patient did not have an adult to stay with them for a week after the surgery, which they needed. So we're rescheduling that for another day. Hopefully we're going to overcome that issue soon. Thank you for watching, and we'll be back next week with more surgeries at Deuk Spine Institute.